Hello to everyone who's joined our webinar today. This is Gerald Winslow from Loma Linda University. And we bring the webinar today on behalf of the Adventist Bioethics Consortium. And I see that a number of you have joined us. Thank you for doing that. I think we're going to be in for a very interesting session about are we making the right decision, talking about how we work through difficult cases in a systematic way. Leading the webinar today are two esteemed physician ethicists with decades of experience in clinical ethics. Let me introduce, first of all, Dr. Grace Wee. Dr. Wee is the director of our clinical ethics service here at Loma Linda University Health, where she serves with her team on a 24/7 basis for all of our hospitals. She is also the associate director for the Center for Christian Bioethics and one of my colleagues in helping to build the Adventist Bioethics Consortium, which all of you are participants in. Dr. Wee is a pediatric intensivist. She has a graduate degree in ethics as well, and somehow she's managed to do all of that while being the mother to two wonderful children, Andrew and Abby. So Dr. Wee, thank you for leading today. And she will be followed in the presentation by Dr. Robert Orr. Oh, Dr. Orr is going first. Thank you. As you can tell, this is not entirely rehearsed, so I hope there's an element of spontaneity. That's right, Dr. Orr is going to go first. Dr. Orr spent about a decade here, a little over, I think, at Loma Linda University, where he was in charge of our clinical ethics service. Then he got the idea he should retire in Vermont, but we lured him back from retirement to do something very special, which was to have a fellowship here to train the next generation of clinical ethicists at our place. So Dr. Orr came to do that. He's one of the most esteemed physician ethicists in the United States, having been recognized by the American Medical Association as a leading clinical ethicist with the prestigious Hayes Bell Award. I would like to advertise his book, Medical Ethics and the Faith Factor, available from bookstores or distributors most every place, but especially from places like Amazon. Subtitle, A Handbook for Clergy and Healthcare Professionals. Dr. Orr, in addition to his many other assignments, has also worked at Fletcher Allen, did I say that right, Bob?
It's no longer Fletcher Allen. It's now the University of Vermont Medical Center.
Okay, thank you for that. And is, in addition to all these other things, a family physician who did extra additional fellowship at the McLean Center with Dr. Siegler, Mark Siegler there. We welcome you both, and Dr. Orr, I understand you're the one who is going to lead out. Just before you do, let me mention to all the participants that down at the bottom of your screen, I understand you can see something that says Q&A. There's a little button down there. If you're in the bifocal age, you may have to readjust your eyeglasses to see it. It's small on my screen, but there's a little file with a Q in it. And if you hit that button, you can submit questions. And I would encourage you to do that even as we go through the presentation. And then as there's time, we'll take up those questions. All right, Dr. Orr, over to you.
Great, thank you, Jerry. Fine, next slide, please. I've been asked to talk about the ethical deliberation. And just a reminder, I expect most of you are members of ethics committees. And they have three functions: education, policy, and consultation. And today we're going to be focusing on consultation. Next. The purpose of an ethics consultation is to identify, analyze, and resolve ethical dilemmas in the care of individual patients. It's a bedside endeavor. We're looking at individual patients. We're not looking at policy here. We're looking at individual patients. What should be done for this patient? And I have worked with a few hospitals that do not document the consultation. And I think that's very poor form. I really think the ethics consultation report should be written and it should go in the chart. And I emphasize that it should be readable, as in having good sentence structure, good grammar, good spelling, and so on. Because if someone is reading your consult report and it's poorly written, they're not going to think this is very valuable information. So I really try to encourage my students to write a very readable report. Next, please. Ethics consultation can be done by a full committee, but not many hospitals are doing that anymore. More are doing a subcommittee approach where 3 or 4 individuals from the committee will work together on a specific consultation. I'm going to be describing the third method, consultation by the individual clinical ethicist, but most of the things that we're going to talk about are easily transferable to the subcommittee method as well. Next slide. I'm going to talk about the components of the report before we talk about the process, because these are the things you're going to be having in the back of your mind. What is it I'm looking for? What am I going to include in the report? Well, of course, the demographic information, the ethics question, the narrative, the story of what's going on, an assessment, discussion, and recommendations. Next. So now let's talk about doing the consult. Next. The request. Who has made the request? Hospital policy should state that anybody involved in the patient's care can request a consult, including the patient or family. I think most hospitals include that, but it should be written in policy. Now, the request you get may come from a ward clerk, and you want to find out who wrote the order for it. And even the one who wrote the order may not be the one who raised the issue. The order may be written by an intern or even by a senior medical student in a teaching hospital. But you want to talk to that person and find out, how did this question come up? And my favorite opener in talking to the requester is, how can I be of help? And I might point out that the request may or may not be the same as the ethics question. And we'll talk more about that in a bit. Next. Now, I'm going to be talking about this in stepwise fashion, in a logical fashion, but I would emphasize that the process may not follow the same sequence when you're actually doing it, because you may go to the ward and find out that the family is there and about to leave, and you may want to talk to them before you review the chart and so on. But the sequence that I recommend is to review the chart first, to learn the demographic information, to learn the history. And this may require looking at old charts and to determine who I want to talk with. Next. And seeing the patient to determine their capacity, their understanding, and their wishes. A few years ago, there was quite a discussion in the ethics literature about whether the ethics consultant should examine the patient. And that was sort of tied into the question of, must the ethics consultant be a physician? And I must say that examining the patient, in my mind, means eyeballing them, looking at them. I usually hold their hand, but a couple times I have actually examined the patient when some particular issue was in question, and that has made a difference, but generally not. Next. Who are you going to talk with? Well, I'm going to talk with the attending physician. Now, a little caveat here. When I'm talking with the requester, I ask if the attending physician knows about the consult request. If they do not, I ask the person I'm talking with if they would be willing to let the attending physician know that a consult has been requested. Sometimes the issue is about what the attending has done or is proposing to do, and the person making the request, nurse or social worker, may have some trepidation about letting them know. So my general approach is to say, well, is it okay if I call the attending and tell them that an ethics consult has been requested? And most often they say yes. In a very rare instance, everybody on the team wants an ethics consult, but they don't want the attending physician to know who requested it or even that it was requested. And so I am then unwilling to do a formal consult. I will meet with the person who made the request, and perhaps with other team members, may sit down and chat with them about how they should or how they might want to interact. But I'm not willing to do a formal consult to go on the patient's chart unless the attending physician is aware of it. He or she doesn't have to give permission, but they must be aware of it. So I also talk with the bedside nurse, any consultants. I don't always talk with all of these people, but after looking at the patient's chart, I will decide which ones I need to talk with. Consultants, therapists, social worker, chaplain, discharge planner. These folks often have information that is not readily available in the chart. Primary physician. Sometimes the physician who has been taking care of the patient for 20 years has information that is really quite pertinent to what is going on. Or if the patient comes from a nursing home, I will often want to call the nursing home and never know who for sure to talk with. Might talk with the nursing supervisor, director of nurses, but I usually say, let me talk with the nurse who knows the patient best. And if the patient lives at home, may have a visiting nurse, and she or he may have valuable information. And of course, I want to talk with the family or guardian and the patient themselves. Next. I'm thinking of, we've missed one slide, but we'll proceed and see. Do we hold a management conference? Once in a while, I'll gather people together before I complete the consult report. More often, it's one of my recommendations that I suggest we have a management conference. And once in a while, I will set it up myself, but more often I will ask the social worker or the intern or somebody else to gather people together. Most often, everybody in the same room. Not infrequently, we'll have somebody on the telephone to be part of the conference. And I usually suggest to the person convening it who should be there. And I'm always glad to facilitate the conference, but sometimes that's better done by the attending physician or the social worker or somebody else in a particular instance. Next slide. Writing the report. Okay, these are the things, remember, that we said we want to include in the report. Next slide. Demographic information. This is fairly self-evident, but everybody should be aware that we want to include the patient's name, medical record number, date of birth, the date of admission, and the date of consult, because sometimes it's pertinent whether the patient came in yesterday or 3 months ago. The location of the patient, the name of the attending physician and what clinical service the patient is on, and the source of the information that I have gleaned. Now, I usually write this in a progress note, but it should be somewhere in the chart. And I'll talk about that in a little bit when I talk about the progress note. Next. Now, the request versus the ethics question. As an example, the person making the request may say, can we write a DNR order for this patient? And that's really not an ethics question. And I sometimes, this is a secret, I sometimes don't write the question into my report until after I've completed the consult. But perhaps in this case, it would be something like this. Is it ethically permissible to ignore this family's request for full treatment when the clinical team believes CPR would be ineffective? So sometimes we can use verbatim the question that the requester asks, and sometimes we need to help to focus. Next slide. The narrative. This is the body of the consult report, and it's important to tell the whole story, the whole clinical picture, what led to the question, and the perspectives, positions, and opinions of the various stakeholders. This is part of the dilemma. This is part of what's going on. And I emphasize to my students that no new information should appear in the report once the narrative is completed. So I've had some students early in their studies add into the discussion that the patient hasn't, into the discussion that the patient has an advance directive. Well, that's really pertinent information. It's a major part of the story. So we need to include everything in the story. So I encourage people to write the report down to the assessment part, review it, and be sure that everything is there that's going to be needed to do the analysis. Next slide. The assessment. This is something that I do and I teach my students to do. Probably not absolutely necessary. In fact, students often have a hard time grasping what this is meant to do, but I think it really helps me to write a 2 or 3 sentence summary of the dilemma, which includes the clinical picture and the ethical dilemma. Now, there's no need to repeat details. You don't have to repeat the patient's age or how long they've been in the hospital or what their family situation is. But here's an example of what I would look for. After a prolonged ICU stay, this man is in multi-organ system failure with a very poor prognosis for survival. His care team wants to withhold CPR, but his family insists that everything be done. That's focused right in on what the issue is and what it is I'm going to discuss in my discussion. Next slide. The discussion is, I think, a very, very important part of the report. Some consultants just look at the situation and write some recommendations. But this is really a teaching part because I like 2 different parts of the discussion. One is a brief discussion of the issue, of the ethics issue, the principles, precepts, precedents, even the law of the ethical issue identified. For example, it may be about autonomy or surrogacy or futility. So I put in a paragraph just talking about this because the person who requested the consult may not be familiar with the precepts of surrogacy. And so I'm going to say, okay, this is what the issue is. And then next paragraph, how do these issues apply in this case? Next slide. Then the recommendations. All right, 2, 3, 4, sometimes 5 conclusions or suggestions. These are almost always optional, and the wording is critical. I've seen some ethics consultants write a recommendation, write a DNR order, or transfer the patient out of the ICU. We shouldn't be writing command sentences. I like to word it is ethically permissible, or it is not ethically permissible, or it would be appropriate to do such and such. So I really want to avoid command sentences. Once in a while, there really is no other option, but it has to be worded tactfully. Should you make clinical suggestions? Should you suggest getting another MRI or another consult? Once in a while, it's okay to write that in the recommendations, but more often, I will transmit that person to the resident or the attending. You know, in cases like this, I've seen sometimes it's helpful to get another MRI to help to reassure the family or whatever. Next slide. Then the sign off. This is just a courtesy, but thank you for asking me to participate with you in deliberations about the further management of this patient. If I can be of further assistance, do not hesitate to contact me, and then identify who you are by name, what your role is, and how to get in touch with you. Because if you just put your name, you're going to have to search around to try to find you, and they may not bother. So let them know. I've even written in, I'm going to be away for the weekend, but you can reach me on my cell phone. Give them the cell phone number written right in the chart. Next slide. The report itself. When I've completed the report, I call the requester or the attending physician and say, you know, I've done the consult, I've put the report on the chart, but here are my recommendations. And I think it's always important to have the report in the chart. And then I write a progress note saying, I was asked yesterday to do a consult on this patient. I have reviewed the chart. I have talked with X, Y, and Z. Because sometimes the house staff are looking at the progress notes and may not think to look in the consult report, the consult section, unless you cue them in. Send a copy to the Ethics Consult Service, and once in a while, I'll even give a copy to the patient or family, if that seems appropriate. Next slide. How about follow-up? This is not a one-time endeavor. Well, once in a while it is, but very rarely. But as appropriate to the case, at least once. And in a teaching hospital, I try when I can to go to the unit where the patient is at about the time the care team are making rounds, just to show up and see if they've read the report and see if they have any further questions. Sometimes I follow the patient from service to service or unit to unit as long as they're in the hospital. And once in a while, I'll even call the nursing home or call the family at home. And this is partly my own curiosity, and primary care physician just can't let go. But I think it's sometimes helpful. And whenever I do follow-up, I make notes for the Ethics Consult Service. And occasionally we'll make notes on the chart as well. Next slide. That's the end of my presentation. If you have any questions, ask Dr. Wee. Because I'm retired. So,
thank you so much, Dr. Orr. You know, I do want to say for all of those listening in that we've posted an article that Dr. Orr wrote along with Dr. Shelton on this. It's called The Process and Format for Clinical Ethics Consultation, and it should be on the website very close to where the sign up is for the webinar. So I do want to say that Dr. Orr taught me how to do clinical ethics consults, and I've really stuck very closely to the process that he just so nicely outlined. And so when we wanted to pull a case for this presentation, just to illustrate how this process, how we go about this process, I actually reached back to one of the first consults that I'd ever done. And this is when I was a clinical ethics fellow with Dr. Orr. This is a 11-year-old patient. Her name, I probably shouldn't say her name, actually. But she's an 11-year-old female with something called June syndrome, or thoracic asphyxiating dystrophy. So what June syndrome is, it's an autosomal recessive disease, and it's a form of dwarfism. And unfortunately, these babies are born with very small rib cages, and then there is an inability of their bone and their cartilage to actually grow. And so as the baby grows older, this rib cage does not actually enlarge, and it is a form of restrictive lung disease because the lungs cannot expand to their full capacity. And then these kids usually develop respiratory distress fairly on in life, and because they have difficulty expanding their lungs, there's also a component of secretion clearance that's difficult. They also get multiple respiratory infections. The other organs that are usually affected include the kidneys, the liver, and pancreas. And to treat this disease, they've done several things. The first is to have effective, what we call pulmonary toilet, or just a good pulmonary regimen to clear the secretions. The second is that they can actually expand the rib cage surgically, so they can put rib expanders into the rib cage to expand the lung capacity. But despite this, severely affected children usually die either as infants or young children. So going back to our patient, she's an 11-year-old female. She has June syndrome. She did get this titanium rib expander surgery that was done. But despite this, she lived in a long-term facility for children. She had chronic respiratory failure. She was tracheostomy dependent. She was ventilator dependent. She'd also had developed liver cirrhosis by this time. And when I put up their developmental delay, she was mildly delayed, but she sure knew who you were. She was, her verbal capacity was not great, but she could sure make her wishes and her opinions known when she was in the hospital. About a year prior to the hospitalization in which the ethics consult was requested, the parents did agree to forego chest compressions if she went into a state of cardiopulmonary arrest. And the rationale at that point was that with the titanium rib expanders, it would be extraordinarily difficult to actually to be able to compress the thoracic cavity in order to get the effect of the chest compressions. So she was living at her long-term care facility. She had increased respiratory distress. They brought her into the ED, and inside the emergency department, her respiratory distress progressed, and she actually went into cardiopulmonary arrest. They called a code blue. They did not do chest compressions, but they gave her 3 rounds of epinephrine before they had return of spontaneous circulation. But unfortunately, throughout this time, this was quite a bit of time where she did not have an adequate amount of oxygen, and particularly to her brain, and she suffered a hypoxic ischemic brain injury from this. And it was clear some weeks after this initial injury that she had suffered severe permanent neurologic injury. So now it's 2 months later in the pediatric ICU, and the team felt like they had been updating the parents. The parents did say that it was okay to limit treatments, to not do the defibrillation. So now we would not only do we would not do chest compressions, we would not do defibrillation. We also would not do dialysis, but it was still okay to give epinephrine and other code medications in the event of cardiopulmonary arrest. The problem is that multiple times per day, she would suddenly start to have severe oxygen desaturations. So her oxygen saturations, I mean, they weren't really great to begin with. They were somewhere in the mid-90s with fairly high fractional inspired oxygen concentration, or FiO2. So usually around 40 to 50%, if I can recall. But she would have several episodes a day where all of a sudden her CO2 level would go up, her oxygen saturation would decrease, and then she would require quite vigorous and aggressive therapy in order to get her out of these episodes. So most of the time, what works the best would be giving her sedation medication and also paralysis. But even with this, 2 days prior to the consult was called, code blue was called, and she again had she had epinephrine, and return of spontaneous circulation was obtained. So now an ethics consult was requested, and the question that we were asked, or that I was asked, was, is this child receiving futile treatment? The team told me when I spoke with the team that the patient would actually like to go back to her long-term care facility. So how do we then incorporate the information that we just learned from Dr. Orr? How do we go about this ethics consultation? So again, anyone involved with a patient's care may request an ethics consult, but I usually find it to be very, very helpful to know who actually is wanting the ethics consult. And I agree totally with the question, how can I be of help? And so in this case, the request actually came from the attending physician. So now we want to go to a question for all of our audience here, audience participation. So just again, a really brief recap. We have a 11-year-old patient with severe hypoxic ischemic injury, and it seems that she's still requiring aggressive therapy in order to prevent her from going into repeated cardiopulmonary arrest. And the question to us was, is this futile therapy? Something that I hear a lot from some of my colleagues is that, well, a question like this is not necessarily an ethical question, it's a medical question. So that's our first question for our audience participation today. Is this primarily an ethics question or a medical question? And I want to go ahead and give our audience about 30 seconds to answer this question. Good. Well, we have about, should we give maybe a few more seconds to answer this question? And I'm seeing that the majority of people are saying both. Absolutely, I would agree with that. This is an ethical question and it's a medical question. When something is this involved, when you have both an ethics question and a medical question, sometimes it can be helpful to understand this from the outset so that we are able to figure out what are the medical components and what are the primarily ethical components. So when I spoke with the attending physician, he related to me that his concern was that she was not getting better. So she'd been in the ICU for 2 months, and he knew that the parents wanted her to go back to her long-term care facility, but they couldn't take her back because the level of care that she currently needed was just too great for them. And if she went back to her long-term care facility, it was most likely she would just come right back into the hospital. He described these events as she was trying to die, meaning that we were having to do such aggressive therapies in order to get her oxygen saturations up that it eventually came down to the question of, well, what are we really doing? So here's our second question. What is the ethical issue or issues under discussion? So please choose all that apply, and I will report out our participants or the issues that our participants feel are most pertinent. But are we talking about futile treatment, non-maleficence, meaning that the physician feels like they're doing harm by continuing treatment? Do we have a disagreement on the goals of treatment, or do we have a disagreement on the prognosis? Is this a question about instituting unilateral withdrawal of support, or are we talking about clinician moral distress? So let's go ahead and take about 30 seconds. Maybe 40 seconds to answer this question. Oh, so I'm sorry. I was told that you guys can only choose one option. That's fine. So we'll see what is the most popular option here. Good. All right. So just a couple more seconds to get your votes in. But from what I see, clinician moral distress and futile treatment are two leading issues. So futile treatment about a third, clinician moral distress also about a third. The next most chosen one was non-maleficence, or patient is doing harm by continuing treatment. Thank you for all of those who've responded. I agree. It was actually very difficult. This case, I chose this case for a couple of reasons. The first reason is because it's one of the cases that was formative in my training as a clinical ethicist. But the second reason is because I think it nicely illustrates how convoluted sometimes the ethical issues can appear to be. I thought that the consultation request actually was not the same as the underlying question. So the consultation request to us was, is this child's treatment futile? But when I spoke with the attending physician, I felt like the question that he was really asking was, can we stop treatment? Is it ethically permissible to stop treatment? And so when we talk about the topics of clinician moral distress, this is one of the biggest areas of clinician moral distress, meaning the clinician feels like they're obligated to provide therapy or care that they feel is unethical. So I did review the chart, and I did go and see the patient, but as a matter of fact, there was a conflict of interest that but a conflict of interest that came up. So while I was doing my clinical ethics fellowship, I was also at the same time doing a pediatric intensive care fellowship. And this is a patient that I'd taken care of as a critical care fellow and now was going to see as a clinical ethicist. So Dr. Orr and I discussed the conflict of interest and whether my seeing this patient as a physician might preclude me from doing the clinical ethics consultation. We decided that I would go ahead and do the clinical ethics consultation anyway, But I do bring this up because we went into this consult very aware that I would have a conflict of interest that needed to be unpacked. I spoke with not only the attending physician, but also the bedside nurse, and then I spent quite a bit of time talking with the family. Again, this consult was years ago, but when I was reviewing my notes, I still remember talking with the family. I still remember the room that this patient was in, and so I'm going to try to flesh out a little bit more of the whole story for you. When I spoke with the nurse, this was a nurse who I had a lot of trust in. She was an excellent, very competent, very well-trained nurse. And her frustration was that there seemed to be no clear goals of treatment from a medical standpoint. And she would tell me that often clinicians would either change or clinicians would make decisions without an adequate rationale, it felt like to her. So either the goals seem to change or the clinicians seem to change or a combination of both. But the upshot was that there were no clear goals of treatment. She also did not know who was actually talking with the parents. So these were parents who still had full-time jobs, but they would come in mostly late at night in order to visit with their child, and they did come in quite often. They were known to be devoted parents. They were also Spanish-speaking mostly. So I spoke with the parents with a Spanish translator, and the one thing that I was really struck by was how grateful they were for the care that their daughter had received up until now. They knew she was sick. They understood the issues. They could see that she required such intensive medical therapy. And again, they were very grateful of the medical care that their daughter had received. And so when I asked what would happen if they felt like their daughter would not get better, and they clearly said, well, if she cannot get better, we understand that might be the case, but if she cannot get better, we would like her to not be in pain. This is a word-for-word quote from my consult, and I remember writing this into my consult because I was very struck by this. So the parents expressed that whenever a doctor asked them what they would like to have done for their daughter, they felt like they did not know the answer that the doctor was looking for. They also said or expressed to me that they did not remember withdrawal of therapy ever being discussed. They didn't even know that it was an option. They believed very strongly in God, and they felt like God would take their daughter when the time was right. So when we looked at I would have to say this is a little bit of a trick question. So when we looked at the question about the ethical issues under discussion, these were some of the things that we listed: futile treatment, non-maleficence, family physician disagreement in prognosis, whether a unilateral withdrawal would be ethically permissible, or even clinician moral distress. But I felt like just one of these by itself would not be enough in order to fully tell the full story of what was really going on with this patient. And so this is what I thought the ethics issue really was. How can the physician and the clinical team partner with the family to make the best decisions for this patient that are consistent with the family's goals and values? Now, is this a medical question or an ethical question, or both? And I think this is very much an entwined medical and ethical question. And the ethical issues that are embedded in this overarching question are certainly beneficence, non-maleficence. Also, the moral authority of a physician and the moral responsibility that a physician has for decision-making for their patient. There's also a component of truth-telling. It's always concerning when a family expresses that their conception of what's going on with their child is different from the medical team's conception. And thinking about the ethical issues this way, I think helps us to be able to examine conflicts of interest. And also, it encourages us to reflect on what we need to do if our personal values differ from the family values. So again, when Dr. Orr talked about the assessment, I echo what he was saying when he mentioned that students often find this confusing. It took me a really long time to understand what the assessment portion was, but I think that if you're able to encapsulate the core ethical issues in one or two sentences, it goes a long ways towards being able to understand how to best help the patient and also the clinical team and the family. So this was the assessment from my consult. This chronically ill child suffered severe hypoxic brain injury, and her prognosis for meaningful recovery is unlikely. Her parents have agreed to some limitations of treatment, but a specific care plan is not in place. Her team believes her current level of treatment is futile. So I think this nicely encapsulates the differences of understanding between the team and also the family, and the need to have both of these parties come together in order to make decisions on behalf of the patient. So the discussion, and again, Dr. Orr discussed how we like to have two parts, a more general part, and then how the ethics principle or the law or et cetera apply to the case. One of the things that came up over and over again, was futile or futility treatment. So how does this fit into our conception of this patient? And again, this was the question that the clinician asked, and I don't take lightly to disregarding the question that the clinician asks, even if I think that the ethical issue is actually something different. I always want to answer the question that the clinician asks. So I want to ask all of our participants today, what is the definition of futility or futile treatment? And this is truly choose the best answer in which you feel, what you feel to be the best answer. So A, if the probability of the treatment success is exceedingly small. B, if the treatment cannot restore the patient to his or her pre-hospital state. C, if the treatment appears to be causing more harm than good. D, if the physician strongly recommends against the treatment. Or E, if the treatment cannot physiologically accomplish the stated goal. And we'll go ahead and give our participants here about 30 seconds to answer this question.
Winslow here at Loma Linda too. Let me just chime in and say that there's no final grade here, so don't spend a lot of time worrying about your answer. Just give it your best shot. But,
yes, thank you.
We promise not to grade you.
Okay, so we have about half of our participants voted, and the majority of our participants said if the treatment cannot physiologically accomplish the stated goal. Yeah, so this is the definition of physiologic futility. And the easiest way to understand physiologic futility is giving a therapy or a treatment that literally cannot or will not work. And I think the most common futile treatment that physicians do is to prescribe antibiotics for a viral infection. But the other choices here talk about probability. They talk about opinion, values, and these are judgments that are made in part with a person's values. So for example, how do we know if a treatment appears to be causing more harm than good? Again, that's a value-laden judgment. Even how strongly a physician recommends the treatment, again, a value-laden judgment. And so when we talk about futility, we can talk about futility in terms of physiologic futility, but we can also talk about futility as being goal-dependent. If the treatment will accomplish the goal, it is strictly speaking not futile. So if the goal is to continue a patient's physiologic life until all medical therapies have been exhausted, no matter the cost, well, that can be accomplished, but there will probably be disagreement about whether the goal of the treatment is wise or whether it's a good goal or even an ethical goal given what is needed in order to produce the result that's desired. So again, futility is goal dependent. If it will meet the goal, it's not futile, but maybe the goals need to be revisited. So then when we go back to the crux of the matter, and again, what I thought the crux of the matter was, how can the clinical team and the physician partner with the family to make the best decisions for the patient? Well, what is the best decision for the patient? It's a best interest standard. We're making a decision for a pediatric patient, and now a pediatric patient who has suffered severe neurologic devastation. What informs this best interest standard is really the parents' goals and values. And the parents' goals and values then need to be taken into account as we talk about the burden benefit analysis, as we talk about the moral authority that a physician has, and also truth telling. So this was the part where I did disclose to the family, and they had actually seen me in the ICU in a physician capacity. So that actually took a little bit of discussing too, just trying to make the family understand that what I was doing was completely different, not completely, but it was slightly different than what I'd done for their daughter before. But honestly, I remember at the close of our discussion, the dad thanked me and he said, thank you for spending so much time and talking to us. And I felt like he was telling me this not as a clinical ethicist, but actually as a physician. So again, conflicts of interest. So when we talk about then a physician's moral responsibility, and especially for decision making, if we're trying to partner together, should a physician offer recommendations for or against treatment, especially in end-of-life decision making, when the decision can end in a patient's death? So let's go ahead and take 30 seconds and answer this question. So is it ethically permissible for a physician to offer a recommendation for or against treatment? Okay, go ahead and close the poll. And yes, overwhelmingly, you had said yes. There are a few no's, and then also there are a few depends. I agree with the yes and also the depends. It does depend on the case, absolutely. So then how do we understand what the physician's moral authority is? Well, this is our patient. This is a patient that we are prescribing treatment, and our moral authority is to make sure that the treatments and the therapies that we prescribe, we truly feel are beneficial. Our patients, they're in a very unique position, meaning that they're vulnerable. They derive all of the benefit from the treatments that we prescribe, but they also derive all of the burden too. So we need to be very careful in the burden that we are ascribing to our patients. This is a great article. It's called The Shared Decision-Making Continuum by Alex Kahn, published in JAMA in 2010. And what I really enjoy about this article is it shows us the continuum of shared decision-making. And so we'll go through just very briefly each of these points here. So on the side where you say patient or agent driven, this is where the patient or the agent takes 100% of the responsibility for the decisions. And in this setting, this is very similar to strict autonomy. The physician meets with the patient or the agent, they present all the options, and the patient or the agent make their own decision. The physician really only provides knowledge. But sometimes patients and their families, they want a physician recommendation. And so as a physician starts to make a recommendation and put more of their own values and more of themselves and their experience into the encounter, they start to take more and more moral responsibility actually for the decision that is made. So the next step on the continuum is a physician recommendation. And this is where the physician explains the options, but also makes a recommendation that is consistent with the patient's lived and stated values. The next stop is equal partners. And this is if you have a long-standing relationship between the physician and the patient. They have a mutual understanding of the patient's values, but also the physician's values. And together, they're truly able to make an equal or shared decision. The next one along this line is called informed non-dissent. And this is where the physician takes more of the responsibility of making the decision, but it's with the understanding on the part of the parents that they can protest or they can disagree, but they don't necessarily have to give their assent, or they don't necessarily have to agree. And this is where the physician bears the most or the major burden of decision making. When a physician takes it upon himself or herself to make a decision under informed non-dissent, the physician is really obligated to understand all the pertinent information, not only medically, but also about the patient's lived and stated values. And the last data point on this continuum is physician-driven. This is the other extreme, and this is where physicians make decisions independent of patient input. This really should only be done along what we call purely medical decisions, or decisions that are not value-laden. So an example would be, am I going to start epinephrine or norepinephrine? So this is a non-value-laden decision. It's a purely medical decision that is driven by the patient's physiology. So yes, I do agree that a physician's ethical duty can include shouldering increased moral responsibility. When we go back to this patient, what really struck me was when the father said, when the physicians ask us what we want to do with what we want for our daughter, we don't know the answer that they're wanting from us. And that to me spoke very strongly that they did not, either they did not understand enough information in order to make the decision, or that they were okay with a physician taking on more responsibility to make a strong recommendation. So these were the recommendations that we gave in this case. Again, this is actually taken from the consult, and I'm glad to say that I still agree with these recommendations. So we said it's ethically permissible for the team to try to get her back to her long-term care facility. But if this cannot be done, to recommend a course of action rather than ask for parental consent for next best medical steps. It was clear that the communication should be improved between the medical team and the parents, and that the communication should be augmented definitely with a Spanish translator, but also with some understanding into some cultural or family dynamics that may be coming into play. I spoke with the attending physician afterwards. We spoke about the need for having a interdisciplinary team. What ended up happening is that after a multidisciplinary conference was held, there was an expanded limitation of treatment that was agreed upon. Pain control was emphasized, and she died in the hospital shortly after. So really the title of this talk was, are we making the right decision? Did we make the right decision in this case? How can we be sure that we're making the right decisions when we have such difficult questions and the information that we have is often or is not complete or maybe lacking? And I think these are the main points here. Have a process and stick to the process. Gather the information. Seek multiple viewpoints. This is something I really believe in. Advocate for the clinicians to practice good medicine. If the treatment is not beneficial, if it's more burdensome than beneficial, then it should be talked about whether to offer that treatment or not. It could be ethically permissible to not offer that treatment at all. I think it's important to examine conflicts of interest closely so that any recommendation that comes out, we know whether it's been swayed by our values. It's important to reassess when clinical condition changes. And then finally, these are really hard questions. And sometimes there is no good answer. There's just a better answer. That's all I have right now. We have a few minutes left for questions. I want to thank all of you for participating in our polls, and I'll open it up for some questions.
Thank you, Dr. Orr, and thank you, Dr. Wee. And I see Dr. Orr put up here. I asked Dr. Wee, I'm retired, but I think he's still on the telephone or on the call here, so we may direct a question to him. Just one comment that came in during the presentation. Stop treatment, in quotes, is a phrase we never use. Adjust treatment to the goals of care, or limit the use of, we consider saying, but we never stop treatment. Any comment on that from either Dr. Wee or Dr. Orr?
I would agree with that. I think adjusting treatment toward the goals, or something that I borrowed from the critical care world as goal-directed therapy. If we know what the goals are, we can appropriately direct the therapy.
Someone also asked, can we get the slide deck from the presentation for review and share it with others? Yes, of course. We want to make all of these available, and we'll do so very promptly. I'm looking at our graduate assistant over here. Will that be done yet today, do you think, or is it already done?
We have to download it and then process it.
Okay.
So it should be up in the next couple of days.
In the next couple of days. So thank you for asking that. And we will make that available on the Adventist Bioethics.org website. I hope all of you have accounts there. If you don't, I would encourage you to set up your own login for your own account. If you're having any trouble with that, just contact us. You can do that easily by going to the email, sending us an email at bioethics@llu.edu, where we coordinate this consortium. Let me just go back and ask a question here too. What happens if, I'm going back to Dr. Orr's comment that he never does a consult without the agreement of the attending. What if the attending, or at least the knowledge of the attending, I guess you didn't say agreement, but what if the attending says, no, I don't accept the idea of having a consult on this. I don't care who asked for it.
I've only had that happen, I think, twice in 25 years of doing consults. And in those situations, I would meet with the nurse or resident or social worker, chaplain, whoever made the request. I would meet with them individually, learn as much as I could, and help to give them some advice on how they might proceed. But I would not do a formal written consult in the report, in the chart.
One of our participants asks if you might say a word or two about the engagement of chaplains in the conversation, for example, in this case that you described, with the family.
I think it's extraordinarily important to have spiritual support, especially if the family is spiritual. I regret that in this case that we did not have the spiritual support person actively involved in this patient's care. But I do agree that that chaplaincy is really essential to a difficult case like this.
And I try to determine what, especially when dealing with adults or with the parents of a child, do a spiritual assessment of what their situation is. Do they belong to a church or a synagogue, and do they have a particular individual on whom they depend, and try to determine what their values are, even to the point of I might ask if they would like me to pray with them or to call the chaplain. So I think it's very important to look at this aspect of the person as well.
I think there's also a lot of room for collaboration between a clinical ethicist and chaplaincy, especially when for example, this was true in this case, when I hear parents express, well, you know, God will take my child. And in this, I mean, this is literally what the parents said, God will take my child when it's her time. And I think there's a lot of theology there that I personally feel inadequate to unpack. And yeah, it would be, I think there's a lot of room in which we could collaborate on how to help patients and clinicians through this situation.
I see that we're down to probably about our last minute here, and as is usually the case, we didn't get to all of your questions. You're certainly welcome to send those to us via email, and we will do our best to answer them. Let me encourage all of you to save the date. Next May 4 and 5, I believe, are the dates, and actually 4 through 6 in Florida for the next annual conference. That will occur in 2020 in May. So well, it'll be a 2-day conference, 4 and 5, but you may need some time to get there. We'll send out the details, and that will be on our website as well. And yes, we will make the PowerPoint available. As we develop other webinars, we would like to have your suggestions, and you may send those as well to bioethics@llu.edu. Or if you see the Contact Us section there on the website, you'll also see a telephone number you can call. That's it from our end. I think we've come right up to the time to stop. Let me thank all of you who chose to participate here today, and especially Dr. Wee and Dr. Orr, who took their time to do this. Thank you very much.